Hello, my name is Miss Katharine Davies and I'm one of the consultant head and neck surgeons working within the Liverpool University Hospital Foundation Trust. The purpose of this video is to highlight the work that we do within our head and neck rapid access clinics, to highlight patients that we'd be particularly concerned about, and also to advise primary care clinicians about certain conditions that are often referred in but can be reassured within the primary care setting. We will see and treat a wide range of patients, including conditions relating to the larynx, hypopharynx and nasopharynx. We see lesions of the salivary gland, thyroid, and also sinonasal and oral cavity pathologies, although the latter two will be treated by our specialist rhinology and maxillofacial colleagues. Head and neck cancers are the 8th most common cancer in the UK, and roughly 12,000 are diagnosed each year. This makes it relatively uncommon, and so when this is shared out between all primary care clinicians, it can mean that the patients with these conditions are seen relatively infrequently. Part of our role within the Rapid Access Clinic is to help promote signs and symptoms that are most concerning for head and neck cancers, and also common risk factors. Alcohol and smoking are the two main risk factors for head and neck cancer. The rates are higher in men than women, and also in patients from higher areas of deprivation. We also know that patients from lower socioeconomic backgrounds tend to present later and can often present as an emergency with either acute airway problems or difficulties in swallowing. Which symptoms are important? We know that head and neck cancers are not seen regularly by individual clinicians within primary care. An important part of our role is to highlight the symptoms or combinations of symptoms that make a diagnosis of head and neck cancer more likely. We know that combinations of symptoms are really important when looking at patients with head and neck cancer. So as well as the symptoms directly on the referral form, like persistent hoarseness, unexplained ulceration or lesion within oral cavity, red or white patch within the oral cavity, persistent and unexplained neck lump, thyroid or salivary lump, it is really important to include any associated symptoms, including weight loss, pain or difficulty in swallowing, persistent unilateral earache, or a lesion within the oropharynx, most likely to be seen within the tonsil. Which patients should GP thinks are high risk? Patients who are smokers, high alcohol intake, and from areas with higher deprivation should flag concern when presenting with symptoms mentioned previously. It is important that this information is put on the referral form, as it helps us triage these patients according to their risk. We also know that HPV is having an increasing impact within tonsil or base of tongue cancer, and we do need to be mindful that these patients tend to be younger, don't have the normal associated risk factors of heavy alcohol and drinking. They do more often, however, present with neck lumps, and so can be picked up through this way. I would request thyroid function tests for all patients where you are concerned about a thyroid lump or swelling. If the patient is not euthyroid, then they would need to be referred to endocrinology in the first instance. When to refer a patient with a neck lump? A patient who has an unexpected and persistent neck lump would need referring through to ourselves. Often we find that patients have had recent upper respiratory tract infections or have concurrent scalp conditions, and in these situations referral would not be needed in the first instance. I would also request thyroid function tests for all patients where you're concerned about a thyroid lump or swelling. If the patient is not euthyroid, then they would need to be re-referred to endocrinology in the first instance. What things do we see that don't need a referral? There are a number of things we see that quite often can just be reassured in primary care. There are certain things that we often see which are just prominent normal structures. For example, we often see, particularly in older and thinner patients, a prominent or tortuous carotid artery, and the carotid bifurcation can be particularly noticeable. If there is no other associated lump or lesion around them, then this is normal and not concerning. The laryngeal framework itself can be very prominent, and this can often be mistaken for pathology. Within the supraclavicular area, it can be common to have a fat pad within that region. And so if this has been present for a long time with no other features, it is also not of concern. Another common referral is for younger, fit, non-smoking females with intermittent hoarseness. In these situations, it's important to have assessed whether a diagnosis of LPR could fit and trial treatment for that first, as the likelihood of malignancy in young female patients with intermittent hoarseness is very uncommon. What to do if concerns but doesn't fit the referral? All hospitals that have a rapid access clinic will have an advice and guidance phone number or email. This is the route where there are any potential concerns that need to be highlighted. The receiving clinician will then advise on the best route for the patient and communicate this with the referring doctor.